All right. Hello, everyone, and welcome to the Infectious Disease virtual event. My name is Matt Flegal, and I am a research scientist. So today I'm going to be presenting on in vivo models for infectious disease research through the years, basically to give you an overview of how things have progressed, if you will, over the last quarter century or so. Do feel free, if you have any questions, please submit them. I will follow up with you via email, so feel free, whatever you wish. So to kind of set the stage, within infectious disease research, in vivo animal models truly are vital. This is a very complex discipline. There are a lot of pieces that have to fit together. And working in lab animals is one of the principal ways that we're able to more precisely model the environment that our therapeutics or even for basic research are going to be applied within. We can use an actual immune response. We can also attenuate that immune response to answer other questions. We can test and better explore the transmission, the pathology of the various infectious organisms. And obviously, if we're going to be testing therapeutics, if we're going to be testing vaccines, animal models are critical. Because at the end of the day, the interactions between these pathogens and the host are very complex. And quite honestly, we get, if you will, surprised more often than not. And the way that we can better put these things together before we move into human clinical trials is, again, using these lab animals. Because at the end of the day, for much of what we do, humans simply aren't appropriate for the research and testing. If the pathogens are serious or even fatal or untreatable, or the conditions create temporary or even permanent damage, it's just not appropriate to test them in humans as the lab animals. But these need to be justified. So that's, if you will, the other side of the coin. Whenever possible, we want to use in vitro, we want to use ex vivo experiments. Those should be our first choice for a variety of reasons. One, animal welfare. We have an ethical obligation to our lab animals to treat them properly, to see to their welfare, to minimize their discomfort along the way. But there are other reasons as well. They're expensive. They're very time-consuming. There's individual variability, not just in between species, but also between the individuals within a species. And on the one hand, that's wonderful, because it's the same in humans. So it better reflects the environment that our therapeutics are going to go into. But on the other hand, it leads to call it a reduction in predictability along the way. Hence the unexpected interactions, the results. And also, is there a good animal model? Is there an appropriate species for what we're trying? Are we sure? And then finally, and something I'm going to talk about a fair amount, is it requires a surprisingly high level of technical skill. And that's an important concept to have. And it's one of the things that tends to get missed when looking at the use of these in vivo models. Yes, they're standard techniques. They are relatively well established. They are relatively consistent in the gross details across the industry. But within that, there is the possibility for error and variability that has nothing to do with the things I talked about earlier as far as the species and the animal individuals, but in how you perform these techniques and whether you're applying them properly. And part of this, if you go through the literature, there are very few good references that have appropriate detail. And appropriate detail can go into a fair amount of depth, and we'll talk about that a little bit as well. But those papers or those presentations that will give you those fine details that may reduce the variability or give you a better, tighter data set? There aren't a lot out there. Hands-on training. There's not a lot of good outside hands-on training events. There are a few places that specialize in them, but not many. And often they are both cost prohibitive, but also they're simply not available in your individual area. So again, yes, there are untold numbers of articles that have, at least as a component within them, some sort of in vivo experiment. But they tend to minimize the descriptions of the actual technical conduct. How did you do the things that you did within this study? They often don't report errors. So the model development, the trials and the difficulties and the learning curves that you went through are often not reflected in it, which means that when you are trying to mimic this paper or this publication that you are pulling from, there's a lot that's left out. Those are the details, and those are the details that can lead you down, if you will, the wrong path. And one of the things that is wonderful in this era of the internet, and I'm old enough to remember when we didn't have one, is surprisingly the details of the technical conduct in a paper aren't actually 100% accurate. And when you talk to the people who are actually doing the work, you may find out that there are differences. So you are trying to mimic a publication that, at least in the areas that you are focused on, may be inaccurate. And there's another thing. Just as there is, if you will, the welfare of the lab animals that we have to be cognizant of, the people working with those lab animals have to have a high degree of empathy. You have to want to take proper care of these animals to be successful in this field. But the downside of that is you tend to lose technical skill because there is a high turnover rate. There is a high burnout rate. It is hard emotional work. And finally, there aren't many good university programs out there that give you good hands-on training in how to do these kinds of studies. So our new scientists that come out aren't enormously well prepared for the actual day-to-day technical challenges that they're going to face. And I'll give you an example before we move on. So oral dosing is probably the most common form of dosing in lab animal medicine. It appears relatively simple. We're going to administer this into the esophagus so that it goes to the stomach, or better yet, we'll talk about that in a second, getting directly to the stomach. It's translatable. Most of the medications that we're going to give down the line to humans are going to be orally administered. So there's a huge positive in administering them that way in our lab animal subjects as well, because it's an apples to apples comparison. So we like that. It's translatable. And yes, it requires a fair amount of practice and work to get a basic competency in this. The problem is basic competency isn't enough. There are so many opportunities in this, one of the most simple and straightforward of techniques to create hidden errors. And the real problem is it will affect your data, and you will never know that your data has been compromised. All you know is what is on your Excel sheet or in your graphs or what have you at the end, but you don't know that that data has been compromised by how you acquired it. And also, in many cases, because there is a high level of technical skill needed, because there is an expense, and it's not just the expense of the lab animals that we're going to work on, there's the facilities around them and the people to care for them and all the rest of these components. So what ends up happening is you try and do as few studies as possible. You want the biggest bang for the buck with them, which is great, except it means that you're not going to have lots of studies. You may be making go, no-go decisions on these studies or on these compounds with 1 or 2 studies. And if you do them poorly, you're going to make the wrong decision. So I alluded earlier, do you give it into the esophagus? Do you give it to the stomach? Are you doing it properly to do so? Because if you give a test material to the esophagus, then did all of it make it to the stomach? Was some of it expelled? Was some of it sprayed out on the cage floor? Possibly. So maybe you didn't give the full dose that you thought you had. And never mind that. Again, it's a great technique because it's translatable and we like that. But is it the right route? Different lab animals have different pHs in their stomach. If you have a test material that cannot tolerate a 3.8 or 4.4 or 1.9 pH, by the time it gets to the GI tract to be absorbed, the compound's already been degraded. And then, do you have the right equipment for these species and strain? And I use this to illustrate, this is one simple, quote unquote, straightforward technique, but so much complexity and so much thought needs to go into the selection and then the application of this technique. So now I'm going to talk about what I have seen over the last 25 years, and I'm going to do it to illustrate how far we've come, but also, if you will, some of the pieces that maybe we have lost along the way that we probably would have been better off not losing them. So this is a picture of me, 1993. And you may notice I got involved in surgery fairly early in my career. So a lot of my examples, as I kind of go further in this presentation, are going to have that. So just bear with me. So when I started in the field, yes, there are regulations. Yes, you must follow them. The Guide for the Care and Use of Laboratory Animals is kind of the Bible, if you will, within at least the United States. There's a PHS policy that's very similar, but the guide is pretty much our standard. Speaking just about surgery, 25 years ago, there was half a page that talked about the regulations covering anesthesia and analgesia. And just to clarify for those of you, for instance, who are in IACUC or QA, regulations is a little bit of a misnomer. The guide applies in specific situations, but it has become, if you will, the voluntary document that we follow as part of the true regulation, which is the Animal Welfare Act. But so with that said, surgery and post-surgical care, less than a page, 4 paragraphs. So 7 paragraphs total, giving you your guidance for working on surgery, which I would hope we would all agree is a pretty serious component and could have impacts on animal welfare. 25 years later, we've gone from less than a page to 9 pages. And it's been expanded greatly. It talks about the training. It talks about the specifics of how to perform proper aseptic technique, how the functions of the team work. It's much more comprehensive than it was. Training. So 25 years ago, it was, for all intents and purposes, apprentice-style training. You, with minimal to no skills, were hired into a university or a company or what have you, and someone who had more experience than you showed you how to do things. Your coworkers were your primary source of any information. And this led to, if you will, a telephone tag style of information. And as anyone who's played that party game knows, what you hear 5 people into that game is not what was originally said, and that happened a lot. And there was also a piece of this where you were being trained by someone who hopefully remembered as much as possible about the person who was being trained, who had trained them, And oftentimes you could go back to someone who was basically inventing it on their own. Another thing, when it started, and this was both good and bad, a vast majority of the people who were performing these techniques on a day-to-day situation were either veterinary technicians or people with high school graduates, with high school diplomas. Most of the time, if you had a more advanced degree, you were overseeing the studies or you were designing the studies, but you weren't working on the studies. Maybe you did that in school as part of your degree, but you got out of that when you started. And so that meant that the scientific judgment on a study tended to be in that scientist's hands who was overseeing the project, the study director, if you will. Conferences, there weren't many that focused on actual technical skills. Again, they might spend 30 seconds talking about, we did these technical things, but then we went on to what everyone was at the conference for, which was, here's the data, here's the graphs. Again, this was a long time ago, so these were 35 millimeter slides in a carousel. And really at the time, ALAS was the group that put this together. And that's changed. That's changed a lot. Not so much in the training. Still very heavily a hands-on apprentice style of training. But now the average person who comes into the field has a bachelor's, often in biology or chemistry or lab animal medicine. But there are a lot of outside training organizations, not the least of which is the one hosting this very seminar. And that's important because if you think about it, 25 years ago, if you wanted to see a presentation, your company was going to pay $1,000, $2,000, $3,000 and take you out of work for 1, 2, 3, 4, 5 days and send you to it. Now, there are webinars, there are events like this, there are online videos. There's so much more information out there. There are textbooks that we simply didn't have back in the day. There are textbooks on surgery, on anesthesia, on technical skills. Back in the day, we had Paul Flecknell's and Wainsforth's surgery and technique in the rat, and that's it. Now we have online forums. You can go and interact with thousands or tens of thousands of people in the lab animal community and ask them questions, and many of them will help you. This is amazing. So one of the things that has led to is there's much more of a sense of, if you will, professionalism. There are industry-wide standards. We have metrics, and we believe in metrics. The conferences started to focus more on this technical refinement. And again, even things like PubMed. 25 years ago, I spent a lot of time in university libraries chasing down physical papers and then taking the plastic credit card that I had from that library, going to the photocopier, photocopying whatever articles. Now, if I need an article, I can go onto PubMed, I can go onto other search engines, and I can just pull it and read it. I used to spend, as so many of us did, you could spend an entire afternoon in a library to get 3 or 4 papers. Now, I can pull up almost every paper. It can be in a foreign language, and I can translate it. That's huge. It gives us so much more information than we ever had. So what about technology? Well, let's just talk about imaging. They were just getting into the field, and they were enormously expensive and rare. And usually they were in human hospitals because you did not have them in a lab animal situation. So the number of times that we would do MRI on a rabbit, for instance, where at 1 o'clock in the morning, because that was the only time it wasn't in use, we would take it to the university hospital and get our scans done and then disinfect the entire area so that patients could come in at 6 o'clock that same morning. And because it was rare and because it was expensive, we didn't use it very much. For drug delivery, we had infusion technologies, and those were often human equipment, human catheters, and the technology was honestly pretty crude. Wonderful if you like rebuilding things on the fly in an emergency, but not very good for out of the box. Even our caging, it was unwieldy. It wasn't designed for our type of use. It lacked ergonomics. They were wonderful. Fortunately, they did a wonderful job protecting our lab animals. They often didn't do such a great job protecting us working with them. But let's take imaging, for example. Now it's expensive, but it's mature, okay? Because most of our lab animal species are small. You know, you're putting it into a 6 or 7 pound rabbit, or you're putting it into a 250-gram rat. The equipment that we had 25 years ago was designed at the smallest for pediatric patients, so a 40, 50-pound human child. Now there's equipment that's actually designed for the size and weight ranges that we worked in. And it's accepted by the scientific community. You had to do a lot of, if you will, selling back in the day to bring these through. Now it's accepted and it's understood, and there's information. And every time you do a study with them, you're not a pioneer. And there are new high-resolution ultrasounds, there are new MRI technologies, and so on. And I'll set the stage a little bit for a brief video, but this video is just to give you an idea. This isn't 25 years ago, this is 15 years ago, and they were some of the first ultrasound scans that I did where things really started to come together, where when you can image the fetal heart of a rat in utero, or you can find complications and genetic abnormalities in larger species that we just never were able to do before. I really think that this imaging really came into its own in the early 2000s. All right. And again, infusion for drug delivery and our skill to do it has kicked in. That up in the upper right-hand corner is a mouse femoral artery. So the black suture that you see up at the top is a little bit smaller than the diameter of a human hair. So we've learned a lot along the way. And again, our practices and our methodology are now standardized. And there are people who make much better specialized equipment. You know, the access technologies and the SAI and the Instec and so on, they've brought real refinement to the technologies that we have. Even caging, there's greater choice. The ergonomics are better for us as well as the lab animals. Our enrichment is better so that we can improve the quality of the animal's experience. And now they're really designed for us to work with them, and they're not just simply housing. And then other thing, we understand, and more importantly, it is generally accepted, so many of these basic concepts now, and that's a huge improvement. So we understand things like the appropriateness of true asepsis and analgesia, not just for the animal's welfare, although frankly, I think that may be the most important, but also because we don't want all of the cascading effects on our study data. We understand that animals guard pain and distress so much better. There's so much more study. So now we can pick up on subtle signs where we just didn't have that information before. And these have been in partnership with human pediatric nurses in the NICUs and what have you, who also have patients who can't speak and articulate. And we've learned from them, and in some cases, they've learned from us. And those technical skills, as I said at the very beginning, have become standardized across the field. And we understand things like pair housing for primates and better enrichment and the effects of ambient noise and how to provide a better environment around our lab animals. Other things that have changed. So I'm being a little facetious here, but ergonomics and safety. In '94, we didn't think about it. Yes, we wore basic PPE. We tried not to get injured, but we didn't do a great job on it. And in real terms, that's why you don't see a lot of people from when I started still doing hands-on lab animal, because our ergonomics were never a focus and we injured ourselves. Wrists, shoulders, backs, eyes, necks. We put ourselves in awkward positions and it didn't do us a whole heck of a lot of good. So now, in part, because as our level of work has increased, the cost of training someone to be able to do it has gone up. So you really want to protect them a lot more. Staff retention has become more valuable. When I started and I was working with non-human primates, in the middle picture, we were wearing those and gloves, and we were working with conscious primates. And if you were to win, if you will, the reverse lottery, where the primate that bit you happened to have herpes B, you could die. You could be on a cyclovir or some other suppressant for the rest of your life. We thought it was amazing when we started getting Kevlar sleeves over in the left. Now you wouldn't dream of working with them like that. And not just the safety of the people working with them, but the safety of the primates is better. We have better materials. We know how to handle them so that they're better protected while we're working. That has been a tremendous change. However, and I kind of like this particular meme, if you will. So a lot has gotten better, but we have become, I think, more hyper-focused and our studies are more streamlined, and that can be all to the good. But as our studies have become more expensive and complicated, we've reduced the number of animals on study. The studies themselves are harder to conduct, so we're less prone and less willing to run them. The skill level is higher, and the actual skill that we need to have high quality data is even higher than that. And there's an attractiveness of expensive technology, but that adds to the cost, which again goes on to reduce, if you will, the instances of doing these. And also, we focus, because there's so many more publications, we tend to accept the publications uncritically and just follow them. So I'll leave you with just a few things to think about that I think have lost their emphasis over the last quarter century, and they deserve a comeback. And one is gather as much data as you can. Something as simple as when your animal is humanely euthanized at the end of the study, look at everything. If you don't look, you're not going to see things. And I can tell you, as so many of my colleagues can as well, that after 1 to 3 decades of this, you get surprised. You get surprised a lot. That surprise is information that you would not have had otherwise. But if you're not looking, if you're trying to reduce the footprint of your studies, then you're losing data. And it's a terrible thing to find out about that missing piece of data when, for instance, your compound fails in clinical trials, because you would have seen it, but you weren't looking. Um, don't discount human interaction. The internet is wonderful. Again, I remember when I got on the internet at work for the very first time, and trust me, there was far less on it back then, but don't focus on looking at things electronically. Talk to people. The wonderful thing about technology now is we can use that technology to then reach out to the people who generated it. You can email the authors of papers. You can call them. Many of them will talk to you. Who doesn't like talking about their work and what they do? And then you can get the real information, but it has become so easy to take a 3-sentence reply on a listserv or read 17 papers. Talk to the people who did the work and learn what they know, and be often surprised by how much wasn't in the information that you had. And then another piece that I would like to point out, I've been training surgeons for about 20 years now. And I will tell you that some of the best surgeons I have ever trained, some of the best lab animal technicians I have ever trained, had high school diplomas, came from other careers, but they were smart and they were capable. And the amazing thing, as I've told so many of my direct reports over the years, is we can read the exact same books that everyone else can. You can educate yourself at work. And I would put out that when you're surrounded by truly smart scientists, you can learn a lot from them, possibly faster. So don't discount these people. Don't kind of put aside these people who have all the skills and all the drive and all the determination and all the intelligence just because they don't fit a certain criteria. And that, I think, is maybe where we have lost the most in this field over the last 25 years. And my hope is that we can get back to looking at the quality of the people and bringing those exceptional people in. And with that, I'm going to say thank you. Again, if you have any questions, please feel free to email them in, and I will be more than happy to answer them. But with that, thank you so much.